as well as the GC member of ISA Maharashtra. And this is an important topic for postgraduates. You can expect it in both in the theory and as well as in the practical sessions. And over to you, Dr. Joy Shankar Jana.
Thank you, sir. I will start sharing my screen.
Please, sir, please.
Thank you, madam. Happy Onam to one and all. I thank ISA Kerala, Madam Samshad Denkar, Madam, Dr. Paul, for allowing me and inviting me to speak on their forum. I've been there last year also. Again, this year also I'm speaking. And I'm also thanking Dr. Venkatagiri, Dr. Rajesh, Dr. Venugopal, and of course, Dr. Binil. We all have been long friends and good friends for a long, long time. So the today's topic, which has been I'll be talking about, is anesthesia for obstructive jaundice. Now, it is given in all the textbooks, and most of there are so many notes and everything is there. So what I will do today is that I will focus on the practical point. So if you get such a long case in the MD exam or DMD exam, how to examine the case and how do you present your case as an obstructive jaundice. So that is a skill, how to take your case that this case is a case of obstructive jaundice. So that is also what I am going to speak throughout, and what are the routinely asked questions during the Viva OC exams. So it is not a theory exam question. It is more I'm talking about the practical part. So how to take the case and how to present your case. So let's start obstructive jaundice, anesthesia for obstructive jaundice, a clinical case presentation in your Viva exam. So always kept as a long case. This usually takes long case about 40-45 minutes, out of which you will get about 20 minutes to examine. So you have to be very focused on what you have to ask the questions, how to examine the patient. And it is like thinking how to take the ward round and while taking your rounds, pre-op visit, intra-op management, and post-op. So all these things will be covered. So when you get a long case of a patient and the patient is lying in front of you and you see yellow discoloration of the patient, and after the initial questions and clinical examination, you get a rough idea. Okay, this is a case of a jaundice. So you should try to build up your presentation in that way, so that all your questions, your examinations will all point out towards the case of a jaundice, and you have to finally diagnose it that whether it is an obstructive jaundice. So you start from the history taking, since it's a long case, you have to include everything, right from name, age, sex, address, occupation, religion, and marital status. The present complaints in the chronological order. Of course, this is all we studied in 3rd MBBS, but again, we have to recollect all our examination, how to examine. History of any past illnesses and drug allergies, personal history, of course, very important. Appetite, any addictions to alcohol and any other drugs, bowel and bladder, diet and weight loss. Family history, history of any family illnesses and genetic illnesses. You can get jaundice in some genetical illnesses. And in women, of course, in menstrual history and the obstetric history. Drug history is also important regarding any history of any drug, blood transfusion, or any history of any contact. So while taking the history, if there are any positive points in the history, please go into the depths, like for say history of any alcohol. So what will you ask? The frequency, the amount of alcohol taken, and the duration since its frequency, how many months, years, or so many years. If there's history of loss of appetite, nausea, vomiting, the color of the stools, the color of the urine, and the amount of the urine, how much urine is produced. History of any abdominal pain, abdominal distension, and abdominal lump you can feel. Then if there's history of hematemesis, melena, or even per-rectal bleed, history of icterus, gynecomastia in males, and loss of hair and libido. These are the history while taking out if there is a history for signs of liver cell failure. And if what is Charcot stride? Charcot stride is the fever, pain in abdomen, and jaundice. This is the Charcot stride. What does Charcot stride tell? That there is a CBD obstruction. It could be because of a stone or a malignancy. This is Charcot stride. Past history of tuberculosis, malaria, past history of any blood disorders in himself and in the immediate family. History of any repeated exposure to anesthesia. Of course, this is not a problem nowadays because Halothane is not used. And if was there any problem after any operative, so post-operative, in the post-operative period. Then comes the general examination part, height, weight, and BMI, pallor, pedal edema, generalized edema, sinuses, clubbing, icterus, palpation of lymph nodes and general JVP. Pulse, palpate for the rate, rhythm, and volume, blood pressure. Then temperature. Then look for signs of liver cell failure. So what are the signs? How will you look for signs of liver cell failure? To start from the head to the toe. So scanty hair, scalp in the axilla and the pubic area, parotid swelling, gynecomastia in males, spider nevi in the vascular territory of the superior vena cava, palmar erythema in both the thinner and the hypothinner ambulances, flushed extremities and bounding pulse, fetal hepaticus, you get a sweet and a musty smell from patient's mouth. Nails, you see for the nail bed, you can sign for icterus and scratch signs on the skin and testicular atrophy in males. Signs of delirium, nightmare, uncooperative patients, where there's seen signs of permanent liver cell failure, that is in patient in hepatic encephalopathy. Such cases obviously will not be kept in the examination. So, but also this signs also has to be seen for. Then where do you see for icterus, yellow discoloration? Where are the various sites where you can see signs for icterus? It is sclera, conjunctiva, gums, palate, nail bed, and of course the generalized skin. Also along with the scratch marks, so that indicates there is obstructive jaundice. Then comes the systemic examination for abdominal examination. Now, whenever you see per abdominal examination directly, don't go into the abdominal system. Start from the oral cavity. The alimentary canal or the alimentary system starts from the mouth. Of course, the mouth we examine for the airways, but while examining the per abdominal case, in case of abdominal presentation, start from the oral cavity. So we examine the oral cavity and then start downwards. So you examine for the teeth, gums, tonsils, and the oropharynx. And in the abdomen, you of course do inspection, palpation, percussion, auscultation. I'm not going to go into the details. We all know about it. And you end your examination of per abdomen by taking an abdominal girth and complete it, say, when you have done a per rectal examination. So this is very vast. During the abdominal examination, look for signs of portal vein hypertension. How to look for signs of portal vein hypertension? It is a sign when there is engorged veins centrally placed around the umbilicus, forming a cluster, which is called as caput medusae. And the blood flows away from the umbilicus. So this is the signs for portal vein obstruction. Then also mention the other systems like the respiratory system. In the respiratory system also always rule out for any effusion, pulmonary effusion. And in this central nervous system, look for signs of depression and rigidity. So after taking the history taking and clinical examination, we will come to a provisional diagnosis. That this is a case which is directed towards provisionally towards the obstructive jaundice. So then the examiner will ask, how will you investigate to prove that your case is a case of obstructive jaundice? So then comes the liver function test. So before the liver function test, you must know bilirubin metabolism. You start in your first MBBS by biochemistry. We all know it. I'm not going to go into details, just the steps. Breakdown phase of hemoglobin, conjugation phase in the liver, alimentary phase, and excretion phase. So I'm not going to go into this. Normal values also we know. Total serum bilirubin, total is up to 1 gram milligram percent, and direct is a 0.25. The bilirubin will come into the urine if the direct bilirubin goes beyond 0.4 milligram percent. So that is when there is urobilinogen in the urine. So you have to also, in the investigation, you must know the urine bilirubin level. Normal values is between 100 to 200. Normally it is present in urine per day. And fecal stercobilinogen is between about 300 milligrams per day. So when it comes to the liver function test, always classify it so that you will not miss any of the tests. So how will you classify? So the test for the excretory functions of liver, test for the metabolic functions of liver, then the liver enzymes which comes into the serum, test for the detoxification functions of the liver, and at the end, of course, liver biopsy and the imaging like ultrasonography, CT scan, and MRI scan. So let's start with what are the tests for the excretory functions of liver. So the excretory functions of the liver is, of course, the screening test, that is urine bilirubin. As I told you, when the direct bilirubin goes beyond 0.4 per milligram percent, you will see bilirubin in the urine. Serum bilirubin, conjugated and unconjugated, estimation of the urobilinogen levels in the urine and the stools. Rose Bengal test and BSP tests are not done these days, and the estimation of the serum alkaline phosphatase. So these are the excretory functions of liver. What are the metabolic functions of liver? Serum proteins, total serum proteins, albumin, globulin, and the AG ratio, prothrombin time and the INR, galactose tolerance test, and estimation of serum cholesterol and cholesterol esters. Then the different liver enzymes which come into the serum is the serum alkaline phosphatase, then serum pseudocholinesterase level, especially if there is history in the family of scoline apnea and all, then you can go for serum pseudocholinesterase. Of course, serum aminotransferases, we know it, which is the SGOT and SGPT. Then serum 5-nucleotide test and the various dehydrogenases tests, LDH, then hydroxyl butyl dehydrogenase and ICD, that is isocentric dehydrogenase. So the various liver enzymes which come into the blood, each of them has got a very specific function. Say, if you say ICD, that is more specific for hepatocellular disease and not increasing the myocardial disease. So each of the serums which comes into the blood has got a specific reason. Coming with the continuing with the liver enzymes, gamma glutamine transpeptidase, which is an important test. This is to differentiate between viral hepatitis from obstructive jaundice by correlating with, of course, with the aminotransferases. This has been also used to assess the effects of alcohol on the liver function. So this test is very important. Then serum ceruloplasmin, it is of course decreased in Wilson's disease and increase in pregnancy and ladies who are taking oral contraceptive drugs. Then serum ornithine carboxyl transferases, this is all the transferases which is detected if there is a liver damage. Along with serum alpha proteins, these alpha proteins, these are synthesized only in the fetal life. In the adult life, it is not there. But if it is present in the adult life, then it detects primary hepatocellular carcinoma. Most commonly, it is the hepatoma. This is usually the first done while we are doing the liver transplants. Then the serum antigens and the antibodies, we all know hepatitis A, hepatitis B, hepatitis C, all those antigens and antibodies, IgA, IgG, and IgM. Then we have the liver kidney microsomal autoantibodies and the mitochondrial autoantibodies. So these are all the various liver enzymes in the serum. Then the test based on the detoxification functions of liver. It is the blood ammonia level. This is to detect hepatic encephalopathy. When there is patient with hepatic encephalopathy, blood ammonia levels are estimated because the ammonia is not excreted from the, is not removed from the liver. And the hepatic acid test to detect the hepatocellular damage. Now, the remaining part of this investigations, for this, you have to complete the rest: hematological investigation, biochemical investigations, all the imagings, X-rays, ECGs, maybe 2D, all this. And then after doing all this, you come to a final diagnosis. So how to make a statement of a final diagnosis? This is, for example, this is a statement: 50 years old lady or a male with obstructive jaundice, with or without signs of portal hypertension and ascites, with and without signs of liver cell failure, with and without signs of hepatic encephalopathy. So if the patient has obstructive jaundice with ascites, portal hypertension, so you can say 50 years old patient with obstructive jaundice with ascites and portal hypertension, without signs of liver cell failure and hepatic encephalopathy. So likewise, this is a complete statement for a final diagnosis. So after the final diagnosis you made before the examiners, the examiner can go anywhere while conducting the liver function test or even while clinical examination. The most commonly asked questions in the exam, as an examiner myself, I can give you most commonly questions which are asked. What are the causes of obstructive jaundice? So again, we classify extrahepatic causes and intrahepatic causes. Extrahepatic causes, you know, it is CBD stone or a stricture of the CBD or parasites in the CBD, C ahead of pancreas or carcinoma of the common bile duct or the ampulla of Fetal. Intrahepatic causes could be like drugs like chlorpromazine, PAS, sulfonamide, and tolbutamide. Then what are the causes of medical jaundice? So what is the hepatocellular jaundice? It is also called the medical jaundice. So again, classify viral hepatitis, antitubercular drugs like rifampicin, INH, and PAS, biliary cirrhosis, and of course anesthetic drugs like halothane chloroform. Of course, both are not used nowadays. Of course, there are some parts of rural India where halothane will still be used, but I think halothane has been practically taken out of our circuit. We used to use a lot of halothane, and it was considered a wonder drug. What are the causes of hemolytic jaundice? Again, classify intracorpuscular causes and extracorpuscular causes. Intercorpuscular is sickle cell anemia, thalassemia, and hereditary spherocytosis. Extracorpuscular is malaria, methyl snake venom, mismatched blood transfusion, leukemia, and Hodgkin's. Congenital is congenital hyperbilirubinemia. Again, classify unconjugated and conjugated. In conjugated, you have the Gilbert syndrome and the Kliegler-Naja syndrome. And the conjugated, you have the Dugan syndrome and the Rota syndrome. Then if you answer all these questions, the examiner asks, what are the other causes of yellow discoloration of the skin? So besides jaundice, so what are the other causes if anybody knows? So these are the other causes, carotinia and neperecurrent therapy. Then the examiner can ask, what are the normal functions of a normal liver? So you must know all that. So synthesis of bile, metabolism of bilirubin, synthesis of albumin, fibrinogen, prothrombin, storage and metabolism, deamination of amino acids, removal of toxins of the blood from the portal circulation, formation of phospholipids, detoxification of hormones and drugs, and of course storage of B12, vitamin A, and iron and copper. Then what is the, if there is ascites? So the examiner can ask, what is the mechanism in which the ascites form with portal hypertension? So the mechanism is increased hydrostatic pressure intravascularly. So there is a decrease in proteins, decrease osmotic pressure intravascularly, increase in the osmotic pressure extravascularly, increased lymphatic pressure, activation of the vasoconstrictive and anti-nitrotic factors. This all leads to the formation of ascites, and this ascites is always transudate in nature. Then what are the causes of fetal hepaticus, the sweet and musty smell which is coming out? So causes of fetal hepaticus is that normal demyelination process is inhibited by liver damage. And therefore, methionine is converted into methyl mercaptan, which gives this sweety, musty odor. If there is spider nevi, these are the small size between 3 to 5 millimeters in size, pulsatile and blanches when you touch on pressure, with the central arteriole and numerous small blood vessels radiating outside. The mechanism is still not understood, but it is seen that because of excess of estrogen in the circulation. Palmaerythema, bright red, warm, thinner, and hyperthinner eminences, which blanches on pressure, most probably due to hyperdynamic circulation. So these are the various causes of the various symptoms and signs which you can see. Then what are the causes of splenomegaly? You know how to palpate the spleen. So causes again divide: infective cause along with viral hepatitis, and of course congestive cause because of liver cirrhosis, portal hypertension, and portal vein thrombosis. Then examiner can ask, very tricky question: what are the normal contents of a normal bile? Like the examiner asks, what are the contents of a CSF? So when you're doing CSF examination, so what are the contents of a normal bile in a normal patient? So it contains liver secretes about 1 liter of bile per day, and it contains electrolytes, proteins, carbohydrates, bilirubin, bile salts, various types of lipids, which include cholesterol, fatty acids, phospholipids, and of course, I just told you in adults, 1 liter of bile is secreted per day. Then, what is a normal portal venous pressure? Because if you are telling there is signs of portal hypertension, they will ask you what is the normal pressure. So, what is the normal pressure? It is between 8 to 12 millimeters of mercury. Then, what are the various sites of portal and systemic anastomosis? Portal systemic anastomosis. So, these are the various sites. Lower end of esophagus, that's why we have the esophageal varices, and we have to go in and do the banding to prevent the bleeding. Around the umbilicus, around the lower third of rectum and anal canal, that's again we have the per-rectal bleeding, melena, and all that, and extraperitoneal surfaces of abdominal organs. There are various options of medical treatment or surgical treatment for a treatment of portal hypertension. So medical is tap propranolol. Then we have the non-shunt procedures, the injection of the esophageal varices, which we do during upper GI scopy. And of course, in the good old days, we used to do a lot of Boehringer operation. Then the various shunt procedures there, the portal cable shunts and the spiral shunts, these are huge, massive surgical procedures. And now you have the non-invasive procedure, which is called as the TIPS. Then what are the causes of hepatic encephalopathy? So ammonia is products produced in the colon. And there's a decrease in the branch chain amino acids and increase in the aromatic chain amino acids. There's increase in the free hepatic acid, fatty acids. There's increased excess of secretion of serotonin and octopamine, and all this will cause hepatic encephalopathy. So just 4 or 5 lines. Whenever they ask what are the causes, you need not start the pathogenesis and how it starts and how it met. So these are just 5 points you can immediately say. Immediately the examiner will go to the next question. That is commonly asked is what are the grades of hepatic encephalopathy? So you can see right from grade 1 to grade 5. Grade 1 is mentally is confused and euphoric. EEG is normal. Whereas in grade 5, it is comatose with no response and EEG is flat. So this is the way you grade the hepatic encephalopathy patients. Then what is hepatorenal syndrome? Most commonly asked questions, and of course, you also should know how to manage it and how to treat it and how to prevent it. So if you see, hepatorenal syndrome is a progressive water retention with hyponatremia, azotemia, and oliguria due to decrease in the renal blood flow. It is usually seen in grade 3 and grade 4 encephalopathy. And patients who are operated with obstructive jaundice will bilirubin more than 8 mg/% in the post-operative period. How to classify hepatorenal syndrome? So hepatorenal syndrome is classified into 3 types. So type 1 is a pre-renal uremia due to the dehydration and absorption of nitrogenous compounds from the patient's gut, that is colon, especially after GI hemorrhage. These circulating endotoxins will have an effect on the renal vasculature. The second type is functional renal failure as a result of diversion of the renal blood flow from the cortex to the medulla in the renal in the kidney, accompanied with reduction in the glomerular filtration rate and sodium retention. And last is acute tubular necrosis, may be precipitated by acute episodes of hypotension. That is why you must rather avoid or prevent getting hypotensive and very severe, deliberate hypotension anesthesia during the intraoperative period. So you have to maintain a normal or rather real normal mean arterial pressure. So what is the mechanism of hepatorenal syndrome? There is excess of endotoxin produced in the patient's own gut and flora, that is from the colon, and due to decrease in the bile salts, which comes on because of the obstruction, bile salts are not there, so the decrease in the bile salts. These endotoxins, which should have been normally removed by the Kupffer cells in the liver, cannot be removed due to the liver damage, and they spill over into the systemic circulation, leading to a type 3 allergic reaction, that is toxic antigen-antibody reaction, and this leads to decrease in the renal blood flow and increase in the renal vascular resistance due to fibrin deposition. So this is the mechanism, but then we must always prevent this hepatorenal syndrome. So how to prevent? So the main aim is to prevent and decrease the endotoxin which is entering into the circulation from the patient's own colon. So you have to decrease the gut flora, increase the bile salts into the patient's gut, maintain a urine output, and treat the bacteria which is entering the circulation during the biliary surgery, because we will be operating and sometimes opening up the CPD. So you have to treat the bacteria which is entering into the circulation. So there's a regime which is followed by the King's College Hospital. King's College Hospital is a big hospital. They have a huge volume of work in London, and they have come up with a regime, this is King's College regime, to prevent renal damage during the patients who are in obstructive jaundice for surgery. So if the bilirubin is around and over 1.2 mg/%, how to manage? If the urine output is maintained over 50 ml per hour, no action. If it is less than 50 ml per hour, start mannitol until the desired urine output is achieved. If it is over 8 mg/%, it is bilirubin, then preoperative start antibiotics with the urine catheter, mannitol infusion to maintain the desired urine output more than 50 ml per hour. And this mannitol should continue not only during the pre-op period, intra and post-operative period, so perioperative period. Why I'm saying 50 ml per hour? Usually males, rather adults, produce about 1 ml per kg per body per hour of urine. So if it is a patient is weighing 50 kilos, around 50 ml per hour. You can go up to 0.5 ml per kg per hour, but around 50 ml per hour, patient's urine should be produced. So along with this, you must always also add hydration. So why mannitol is used? Mannitol is used to keep the renal tubules flushed out and prevent accumulation of bilirubin during the causing the renal damage. Then comes administration of bile salts, sodium taurocholate 3 days preoperatively to decrease the gut flora, tap neomycin, decrease the colonic pH by lactobacillus and lactulose, and avoid giving NSAIDs, aminoglycosides, and contrast agents. Why I'm saying the contrast agent? Because these days patients go for various MRIs with contrast studies like MRCP and all. They push in a lot of contrast. And this is one of the causes which can lead to hepatorenal syndrome. Of course, the concept of giving bile salt, that is sodium taurocholate and tab neomycin, is not used. Only they use now to decrease the colonic pH by using lactobacillus and lactulose. Then they'll ask you, what is vitamin K therapy? Why do we give vitamin K? So in obstructive jaundice, when the prothrombin time is not normal, vitamin K derivatives are given in the dose of 10 mg in the intramuscular or IV 6 times a day for 3 days. So rather 4 times a day for 3 days. That means 6 hourly. So, and also you must keep fresh frozen plasma ready before induction if the prothrombin time is prolonged. Then what are the causes of cirrhosis? Common causes of cirrhosis. So what is cirrhosis? It is a chronic diffuse liver disease characterized by hepatic cellular necrosis and proliferation of connective tissue and nodular regeneration. The causes are hepatitis B and C, chronic alcoholism, prolonged cholestasis, and congenital, of course, Wilson's and hematopoiesis. Then, what are the various tools to predict the perioperative risk in a patient with obstructive jaundice and cirrhosis undergoing surgery? So there are various tools. Commonly followed tools are the child-centered criteria and the modified child-to-coat and book scoring system is called as a modified CTP system. So this will give a rough idea of the prediction about the risk factors of the patient. So what is child and criteria? It is divided into 3 grades and it takes into the account bilirubin, albumin, ascites, the CNS status, the nutritional status of the patient, and depending on this, the risks are given as in A, good, B is moderate, and in group C, it is poor. But better systems have come up, which is a little more accurate. They are not very accurate, but more accurate. It is a modified CTP system in which they have included albumin, prothrombin time, INR, bilirubin, ascites, and NPP. So depending upon the various points, you can classify them into class C, A, B, and C, and depending upon that, the risk score is stratified. Then come to the, so up till now, if you come up to here, that means your Viva has gone really good. Now the anesthetic part will come, because till now, if you see, we are already discussing about the medical part and the medicine part. Now the anesthesia part comes. So in the preoperative preparation, always after examining the patient is posted for some surgery, cervical surgery or some CBD, stone surgery or whatever, you must do the perioperative pre-post risk stratification scale, and accordingly the scoring system of using the CTPA, because while taking the consent, you must explain the patient the risk factor. So this is why the CTPA score. So depending on that, you can book for ICU bed or maybe ventilator and all that. Identify the coexisting medical problems the patient has, whether it is cardiovascular system, renal system, coagulation system, or the respiratory system. So coexisting system also has to be elaborated. Intravascular fluid volume, electrolytes, and nutrition of the patient. Parenteral vitamin K and is the prothrombin time is prolonged. So you start the vitamin K 3 days prior to it, and fresh fluid plasma should be kept ready during induction. Proper hydration and urine output should be maintained prior to the surgery, especially if the bilirubin is more than 8 and there is a decrease in the urine output. So IV hydration, antibiotics, and mannitol should be started in the preoperative phase. Arrange for fresh blood and FFPs if the surgical blood loss is expected. Pre-medication, antacids. Now, of course, pantoprazole is there. Antiemetics, antibiotics, anxiolytics, depending upon the patient's anxiousness. Regional anesthesia can definitely be given if the coagulation status is within normal limits, and induction, thiopentone or propofol, depending upon the cardiovascular status and the hemodynamic status, can be given. Intermediate if there is hypotension and all that if the patient is dehydrated and you want to prevent the hypotension during induction. Injection succinylcholine choline. Injection succinylcholine choline can be given, but if it's a very severe liver disease, then pseudocholinesterase may be not there or maybe not produced. So choline can be avoided in such cases when there is severe liver disease. Non-replacing agents, you can use vecuronium and atracurium and of course atracurium. Initially, you require a higher dose because the volume of distribution is more, and elimination half-life of vecuronium is not increased until the dose exceeds more than 0.1 milligram per kg. Intra monitoring and management. Main aim is to maintain the blood flow to the liver and the splanchnic circulation. So careful attention to oxygenation, avoid hypotension and hypothermia. Hypothermia prevention is very important. So take all the measures to prevent hypothermia. Maintain the carbon dioxide, end-tidal carbon dioxide in the normal range. So no hyperventilation or no hypoventilation. EtCO2 should be kept in the normal useful range. Oxygen nitrous with the isoflurane or sevoflurane in intermittent positive pressure ventilation in close-up is ideal. Epidural can be given for anesthesia purpose, which can be used for anesthesia intraoperatively and continued in the post-operative period. Monitoring, of course, pulse, NIBP, saturation, EtCO2 is the basic monitoring. Along with that, temperature monitoring with the peripheral nerve stimulator for the relaxants to be given, and of course, urine output. So in urine output, don't use the routine urine bag, use the urine meter. So every hourly you can calculate how much of urine is coming out and maintain the record every hour. Invasive monitoring, you can put a central line or arterial line depending upon the type of surgery and the medical condition the patient is on. And intraoperatively, you can, if it is a prolonged surgery like a Whipple, which is going on plus 6 hours, you can have an intraoperative ABG and blood glucose monitoring. If the patient, now this is a very important point, if the patient requires a blood transfusion or a FFP transfusion, always start a little earlier. So don't wait till the blood loss has happened or it has gone around maximum hour blood loss. You know the blood loss is going to happen. So start the blood transfusion and the FFP transfusion little before and give it slowly. Why I'm saying this? Because all this blood and blood products contains the citrate. And citrate is metabolized in the liver. Liver is already damaged, so there will be citrate intoxication. So always start blood transfusion a little earlier and give it slowly. If we are going to do any esophageal interventions, like putting a large size endotracheal, rice tube or the nasogastric tube, or you want to put a esophageal echocardiogram probe, then always rule out that if there is no signs of varices. It could be grade 2, grade 3 varices. So while putting it, you can itself cause a bleeding while putting such interventions. Reversal and post-op care. It is usual with neostigmine and glycopyrrolate. Epidural infusion can be continued for anesthesia. Correction, if there is any hypothermia, correction of hypothermia. You can have, if the patient is a chronic alcohol, you can have manifestations of alcohol withdrawal and should be treated accordingly. Of course, O2 mask, monitoring of pulse, BP saturation, and urine output should be maintained. One most important part is that strict aseptic precautions should be maintained during all the surgical procedures, because these are the patients who are very, very likely to catch any infections. So you have to maintain the very strict aseptic precautions. One thing which I missed was, which I could not include, including it now, is how to evaluate a patient with cirrhosis and ascites. If it has got jaundice, it has got cirrhosis as well as ascites. So evaluation of the liver disease, hematological liver function coagulation test, of course, imaging like USG, CT, MRI, and upper GI scope and biopsy. Evaluation of the renal system and the circulatory system, serum creatinine, urea, electrolytes, so urinary sodium and urinary proteins, and cardiac evaluation. You can go up to the bubble test, bubble echo, and evaluation of the ascitic fluid, cell count, culture, and proteins. So we know that the ascitic fluid is infected. If your Viva has come up to here, that means you are really, Viva has gone really good. Then the next question we can ask them, we ask for the liver transplant patients who are going to be posted, is what is hepatopulmonary syndrome? There's a difference between hepatopulmonary syndrome and portopulmonary hypertension. So what is hepatopulmonary syndrome? I'm not going to, this is just about hepatopulmonary syndrome. It is a triad of end-stage liver damage, increased alveolar arterial gradient, and intrapulmonary vascular dilatation. Clinical features: digital clubbing, cyanosis, dyspnea, platypnea, orthodeoxia. I'll tell you what is orthodeoxia, and signs of portal hypertension. So what is orthodeoxia? It is an arterial oxygen desaturation that is more in the upright position and is related by recompensation. Pathogenesis: it is related to intrapulmonary vascular dilatation. It is diagnosed by contrast and enhanced echocardiography, which is called bubble echo. Perfusion scan, lung perfusion scan, pulmonary arteriography. Treatment, medical line of treatment is very limited. It is mostly treated with orthotopic liver transplants. So this is a very vast topic of liver and obstructive jaundice, and very concisely I have presented the most salient points. Of course, we have to go to the text and read. And thank you. So all the further postgraduates, the extra reading which is more required is about clinical history taking, examination, investigation. We can go to any investigations. You must know how to know about viral hepatitis, treatment of acute liver cell failure, acute liver failure coming for surgery, and of course, finally, the liver transplant. So thank you for a patient listening. Thank you, IISc Kerala. I end my talk on this.
Dr. Joy, there is one question.
Yes,
Child
yes,
C patient with INR2 coming for fracture lower limb. Can we give GA or spinal?
I can't get you. Please repeat, sir.
Child C patient with INR2 coming for fracture lower limbs. Can we give GA or spinal? That's a question from Dr. Muthugama.
Yeah. If the INR is 2, it is better to avoid any regional or any neuroaxial techniques. Better to go for GA. But it is type C. So before you take the patient, as per the CTP, am I getting it correct? The CTP score is
C. Yeah.
Yeah. So if you see the risk stratification score in C, the risk is very high between the. So you have to explain the patient and the relatives of the patient is a child. Explain the relatives that he is falling in category C with an INR of 2. So according to the modified, so this is where the pre-op counseling comes and very important. Such patients are going to be a little bit difficult in the intraoperative period, the post-operative period. So after explaining the risk stratification score, of course, definitely giving a regional technique with the INR of 2 will be a little dangerous. Of course, preparation for fresh frozen plasmas and all those can be taken. I hope it answers the question.
Dr. Muthukumar, are you satisfied with your answer, or you want to
add
clarify more?
More clarification, sir? You unmute yourself, Muthukumar, sir.
Dr. Muthukumar, please unmute and ask.
Please unmute.
Sir, I just want to know, sir, how frequent is the spinal hematoma in these patients who have this coagulation imbalance? Like they are in sometimes thrombotic phase or sometimes in the bleeding phase. Like we don't know what will be their balance. How frequent is the spinal hematoma? We take the risk of GA or the risk of spinal hematoma? There is the confusion.
That whether you want to give spinal or you want to give GA, that decision is at the discretion of the practitioner. After examining the patient and after seeing if there are no bruises, no skin hematomas, no nothing, and if you can analyze the platelet, that is platelet function analysis. Even with a low platelet count, you can still go ahead, but that discretion is with the practitioner. We cannot. These are just broad guidelines. These guidelines are not strict. So if you see the patient is clinically okay and you can go ahead with a spinal or a regional, definitely you are justified. But if the patient is already falling in type C, please explain the perioperative morbid risk factor. That is why the CTP score is very important, especially in cases of jaundice.
Okay. Thank you so much.
Thank you, sir.
Especially with the recorded score of INR2, it's at least for medical legal purpose, it's very not fair to go for spinal. So another question is by Dr. Sanjay Kalyani.
Yes, sir.
Kalyani is role of MELD scoring.
Pardon me again.
Role of MELD, MELD scoring.
MELD. These are the MELD scoring. There are two types of scoring. One is MELD scoring and one is PELD scoring. MELD scoring is done for prediction of the morbidity and mortality during if the patient is posted for liver transplant. And PELD is for the pediatric liver transplant. So MELD scoring is done. So if the score is more than 20 or 25, that means the mortality and morbidity is much higher and maybe not posted for liver transplant. Same thing with PELD scoring. PELD scoring is the pediatric scoring system, where these are risk stratification scoring for the liver transplants.
Okay. Another question is, what are the causes of deterioration in post-ERCP patient in ICU?
ERCP is a very dicey part because ERCP is done in the ERCP suite or the endoscopy suite. And if you see the sterilization, even the scope which goes in, I doubt it is sterilized only with sterilium and the various guide wires. If you see, ideally, the whole system should be sterile, including the guide wires and all. The most common thing is the sepsis, either in the common bile duct or pancreatic duct. So there are very high chances of patients developing pancreatitis or infection in the common bile duct. And if the infection develops in the common bile duct or in the biliary system, the most common factor is the gram-negative sepsis. If the gram-negative sepsis takes place, the patient deteriorates. It is very difficult to treat if the patient is having gram-negative sepsis. And usually all this biliary infection lead to gram-negative sepsis. So these are one of the very biggest reasons why the patient may deteriorate immediately or even after 48 hours after doing an ERCP. So that is one of the big factors.
Okay, thank you.
Thank you, sir.
Any more questions from the postgraduates or faculties?
This was a very huge topic, Rajesh.
Yeah.
I tried to finish it. So
Dr. Meenakshi Sundaram is there.
Yeah, good evening, sir. I presented during the Pudukkottai, Bhutan, same topic. Meenakshi, sir.
Meenakshi, Dr. Meenakshi Sundara is there. I can see. He has to unmute and give his comments. Any comments from the other faculties or postgraduate students?
Rajesh.
Yeah.
Thank you, Dr. Joyashinkar Jana.
Thank you.
You are concentrating mainly for the PGs.
Only PG.
What are the questions that were asked in the PG exam?
Yeah.
So the PGs might have very useful for that. I think so. That was you have covered almost all of the topics, and the PGs has to read all these things in detail.
Yes. That is
That's
more
the
important.
main advice that you have given.
Yes.
It's a huge
Okay.
topic.
Yeah. Yes. Okay.
Madam,
Dr. Meenakshi Sundaram. Sir.
yeah, madam.
Namaskar.
Dr.
Okay. Good
Jana,
evening, sir.
Dr. Jana's flow was without any obstruction.
Yeah.
Even though it is obstructive jaundice, he has clearly mentioned everything. So it is good. We are waiting for the next topic only.
Yes, sir.
So there is one more question from Dr. Rajani.
Yes, sir.
Can we give a total intravenous? I think it must be TIVA.
Yeah, Tiva.
Yeah, TIVA. You can
Okay.
for non-operating room anesthesia in chronic liver disease, liver failure
Yeah.
patients.
Yeah, definitely you can give Tiva. Of course, while giving Tiva, first thing you have to keep in mind the hemodynamic status and of the patient, how much, whether he's dehydrated or whether he's overhydrated, presence of ascites, all those. Tiva also maintains the blood flow to the liver as well as to the splanchnic circulation. Of course, inhalation, there is nothing against inhalation agents. If the question is asked in the exam whether to give Tiva or give general anesthesia or inhalation anesthesia, you can say, I will use a mixture of both, a little bit of Tiva and little bit of mixture, so I can get the best effects with the minimal side effects. Because the main reason is to maintain the blood flow to the liver and splanchnic circulation. So there is no harm. Of course, you have to see the hemodynamic status. With Tiva, if the blood pressure keeps on falling very hard, you have to decrease and you add up.
There's a couple of more questions about active bleeding after insertion of scope, what to do. And another question is which muscle relaxant?
Muscle relaxant most commonly now used is Excretory and Cis-Excretory. There is no doubt about it because it is not metabolized. It is metabolized into the cytocolitis with the esterlysis. So Cis-Excretory can be safe and Excretory can be safely used. Of course, there is no absolute contraindication to vecuronium. You can use vecuronium also. In liver transplant, we use vecuronium because it is better because post-operatively also patient remains in the ICU. Of course, it's up to the discretion of the practitioner. You can use atracurimus or vecuronium. There is no contraindication to anything. But better you can use atracurium. Yes, sir.
Patient with active bleeding after insertion of scope, what to do?
Scope means transesophageal echocardiogram.
Must be it is in the context of ERCP.
Yeah, this is very commonly faced, and that is the reason you have to be very careful.
Endoscopy.
During endoscopy, especially during upper GI scopy, where they want to do sclerotherapy or banding of the esophageal varices or do ERCP. So that the scope passes to the lower part of the esophagus. If usually they have this imaging, there is history that there is hematemesis and there is bleeding. It is always better to put a smaller size cuffed endotracheal tube because sometimes the bleeding can be very torrential and can come up under general anesthesia and can lead to aspiration of blood into the lungs and the tracheobronchial tree. So in such conditions, this has to be predicted. This has to be discussed before giving anesthesia with the endoscopist. How big is the varices, whether it is grade 1 varices or grade 3 varices. Usually they can make it out from the imaging. But sometimes you give little bit of sedation and just want to know, I just want to assess. And then they go down and then suddenly it starts bleeding. It is better to come out. If you have to give GA, if they want to proceed, do like a rapid sequence in RSI induction. rapid sequence intubation, because the blood can anytime come up when you give the gene. So this is how you give anesthesia during, if there is a sudden bleed during the endoscopy of the esophageal varices. Does it satisfy the answer and the answer to the question?
Yeah. Any comments from any faculties?
Yes, sir.
Or we can go to the next session.
Yeah.
Next is the postgraduate session. We have Dr. Rahul Anand, the faculty, as well as Dr. Binu Sajid is there. Over to Dr. Rahul. Dr. Rahul, please.
Yes, sir. Can you hear me, sir?
Yeah.
Yes.
Okay. On the onset, I would like to thank Indian Society of Anesthesiologists Kerala State Chapter for giving us an honor and an opportunity to our postgraduates to present the topics. I would like to also thank Dr. Jana for coming online, spending his valuable time and giving a talk on such a valuable topic, which is of utmost importance. And surely, and I'm sure that obstructive jaundice is a must-do topic for the examination, and invariably the students would be asked questions about it, whether as a long case or as a short case. The Government Medical College, Kannur, I think it's first time coming online in the Kerala state today. I mean, for the PGs are coming first time. And we have the first PG presenting today is Dr. Blessy Babu. She is our first year postgraduate student. She did her MBBS from Jubilee Mission Hospital, Thrissur. She would be giving her topic of today is low molecular weight heparin. So I now ask Dr. Blessy to please come forward and present her topic.
Am I audible?
Yeah. Yes, Blessy, please carry on.
Thank you, sir. So,
Please share.
Share your screen, Blessy. Share your screen.
Yes, sir. I will share. Can I start?
Yes, Blessy, continue.
Okay, myself, Dr. Blessy, first year junior resident from Government Medical College, Kannur. Anticoagulants are one of the most common drug group we are all familiar with. And anticoagulants are the class of drugs that prevent coagulation or clotting of blood. And low molecular weight heparin is a class of anticoagulant medication and most commonly used anticoagulants. And my topic for today is low molecular weight heparin. So, low molecular weight heparin, they are synthesized from unfractionated heparin by chemical and enzymatic depolymerization. Now, about their chemistry, the mean molecular weight is about 4,000 to 6,500 Dalton, and the molecular weight ranges from 2,000 to 10,000 Dalton. These fragments are 1/3 the size of heparin, and their chain length is of 13 to 22 sugars. There are different types of low molecular weight heparin. This is a small classification based on the mode of synthesis. Enoxaparin and dalteparin are the most commonly used low molecular weight heparin. Enoxaparin is synthesized by benzylation followed by alkaline depolymerization. Dalteparin by nitrous oxide depolymerization. Other low molecular weight heparins are natriparin, argiparin, pinzaparin, reviparin, and danaparin. Now, a small comparison between heparin and low molecular weight heparin. Compared with heparin, which has an anti-factor 10A to anti-factor 2A activity of about 1:1. At the same time, for enoxaparin, this ratio varies between 4:1 and 2:1. Low molecular weight heparin bind less avidly to proteins than heparin, so it makes them have a better bioavailability even at low doses. Then, compared to heparin, low molecular weight heparin have a longer half-life So their dosing is more predictable. Less frequent doses are used, most commonly once per day. Although protection against venous thromboembolism in high-risk medical and surgical patients is often thought to be better with low molecular weight heparin than with heparin, low molecular weight heparin's effect is greatly prolonged with renal failure, and anticoagulants such as unfractionated heparin should be used in this population. Now about the mechanism of action. Low molecular weight heparin or anticoagulants act by inhibition of final common pathway of the coagulation cascade, which is the conversion of fibrinogen into fibrin by the activity of thrombin. Low molecular weight heparin inhibits coagulation by activating antithrombin 3. Antithrombin 3 binds to and inhibits factor 10A. In doing so, it prevents activation of final common pathway. That is, 10A inactivation means that prothrombin is not activated to thrombin, thereby not converting the fibrinogen into fibrin for the formation of a clot. Heparin also works similarly by binding antithrombin 3 and activating it. Heparin has a binding site for thrombin also, so that thrombin can interact with antithrombin 3 and heparin, thus inhibiting coagulation. So heparin has a faster onset of anticoagulant action as it will inhibit 10A and thrombin. Meanwhile, low molecular weight heparin acts only on a 10A inhibition. Then about the administration and dosing. Low molecular weight heparin is mainly administered by a subcutaneous injection. Then regarding the dosing, dosing can be made therapeutic dose and prophylactic dose. Therapeutic for enoxaparin, therapeutic dose is 1.5 milligram per kilogram per day or 1 milligram per kilogram 12 hourly, and prophylactic dose is 40 milligram per day. And for dalteparin, therapeutic dose is 200 units per kilogram per day, and prophylactic dose is 2,500 to 5,000 units per day. And as I already mentioned, low molecular weight heparin effect is prolonged with renal failure. So we have to delay surgery for 12 hours after last dose of low molecular weight heparin in patients with normal renal function and longer with renal dysfunction. Dose adjustment is required or precaution is advised for creatinine clearance less than 30 ml per minute. Now about the indication, mainly indicated in deep vein thrombosis prophylaxis and in treatment of venous thromboembolism in pregnancy, pulmonary embolism, ST elevation, myocardial infarction in both who are those undergoing percutaneous coronary intervention and those who are not undergoing intervention. Then stable angina, prevention of clotting in extracorporeal circuits. As we all know, COVID is a hypercoagulable and prothrombotic state. So in COVID, there is high risk for venous thromboembolism and thrombosis. So in all hospitalized patients, prophylactic dose of low molecular weight heparin is indicated. Now about heparin usage in hospitalized COVID patients without evidence of venous thromboembolism. Prophylactic dose is indicated in patients who are without any oxygen requirement or requiring mechanical ventilation or extracorporeal membrane oxygenation or requiring oxygen through high flow nasal oxygen or non-invasive ventilation, and even in supplemental oxygen. The therapeutic dose is given only for non-pregnant patients with D-dimer levels is more than upper limit of the normal, who are not at increased bleeding risk. And there are also unless low molecular weight heparin is contraindicated. Contraindications for the use of therapeutic anticoagulation in COVID-19 patients include platelet count less than 50,000, hemoglobin less than 8 gram per deciliter, and there is a need for dual antiplatelet therapy. And the patients who had bleeding within the last 30 days that required emergency visit or hospitalization, history of any bleeding disorder, inherited or actively acquired bleeding disorder. Then about now on COVID positive pregnant woman and low molecular weight heparin. Physiological changes in pregnancy makes it a hypercoagulable state. COVID is also an hypercoagulable and prothrombotic state. These two together will increase the risk for thromboembolic events. The American College of Obstetricians and Gynecologists advises that although there are no data for or against thromboprophylaxis in the setting of COVID-19 in pregnancy, Venous thromboembolism prophylaxis can be reasonably considered for those who have severe disease. Now about the monitoring, no regular laboratory monitoring is required. If monitoring is indicated, anti-factor 10A activity assay is done, and the range of the anti-factor 10A must be kept between 0.5 to 0.8 international units per ml. APTT is relatively insensitive indicator. PTINR also used. Now about the adverse effect, main risk is bleeding. Then there are some other less common adverse effects like heparin-induced thrombocytopenia, osteoporosis, spontaneous fractures, hypoaldosteronism, and hypersensitivity reactions. One of the advantages of low molecular weight heparin over heparin is that these side effects are less common with low molecular weight heparin when compared to heparin. Then about toxicity, protamine is the main antidote used in cases of toxicity. Protamine sulfate will reverse the low molecular weight heparin associated with, but it reverses it partially, and also the reversal depend on the time from the last administration and dose. Protamine sulfate is a cationic peptide. It binds to low molecular weight heparin, forms an ionic complex with no anticoagulant effect. Then about the dosing in and dosing of protamine, 1 milligram of protamine is given for every 100 anti-10A units for enoxaparin, and it is given within first 8 hours of administered low molecular weight heparin. And if bleeding still continues, 0.5 milligram protamine per 100 anti-10A units is given. Smaller doses needed beyond 8 hours after low molecular weight heparin. As I already mentioned, reversal is partial. It indicates that protamine neutralizes 65% of anti-10A activity and 90% of anti-2A activity. Then contraindications, mainly hemorrhagic disorders, then peptic ulcer disease, recent cerebral hemorrhage, severe hypertension, and recent surgery to the eye or nervous system. Now, a few words about the most commonly used low molecular weight heparin, that is enoxaparin and dalteparin. First, about enoxaparin. It is synthesized from standard unfractionated heparin after depolymerization, and they yield 1/3 the size by heparin. And their molecular weight is approximately 5,000 Dalton, and it binds less avidly protein. And this feature contributes to its superior bioavailability and predictable effects. And it has a longer T-half, so once daily dosing without monitoring is an advantage. Then most commonly we are giving in the subcutaneous form. So if we given in subcutaneous form, there is bioavailability is 90%. Intravenous formulation is also available. No topical form is available. Intramuscular administration is generally avoided. 1 milligram of enoxaparin is equal to 100 units of anti-10A activity. Now about dalteparin. Dalteparin is also a low molecular weight heparin with antithrombotic properties. It enhances inhibition of factor 10A and thrombin by antithrombin. It has a bioavailability of 87%. Dalteparin also have a longer apparent terminal half-life, about 3 to 5 hours, possibly due to their delayed absorption. It can be administered subcutaneously only. Now about the anesthetic implications of low molecular weight heparin. Main concerns regarding anticoagulant therapy come into play while we consider regional anesthesia, especially central neuraxial blockade. This is the NISORA guidelines regarding needle or catheter manipulation and anticoagulant therapy. It's mainly discussed under 3 headings. First, when neuraxial block can be performed after the last dose is given. So if a patient is on prophylactic dose, the procedure can be performed 12 hours after the last dose. And if patient on therapeutic dose, last dose must be given 24 hours prior to surgery. These are the guidelines when neuraxial block performed after the last dose, 12 hours after last dose for prophylactic dose, and 24 hours after last dose in case of therapeutic dose. Then now on our concerns when neuraxial catheter is in situ. Here the treatment dose is not recommended. If prophylactic OD dose is considered, first dose is given 24 hours after the catheter placement, and catheter can be removed 12 hours after the last dose. Then there are guidelines on restarting the therapy after neuraxial block or catheter removal. So a prophylactic dose can be restarted 4 hours after the removal of the catheter. In case of treatment dose, first dose should be given at least 4 hours after catheter removal. But at the same time, if the procedure is a non-high bleeding risk surgery, the it can be the low molecular weight heparin therapy can be restarted 24 hours after the non-high bleeding risk surgery and 48 to 72 hours after high bleeding risk surgery. That's an ISORA guidelines regarding the low molecular weight anticoagulant therapy and regional anesthesia. So, in conclusion, the low molecular weight heparin is on popular use because of its ease of use, and there is no need of laboratory monitoring, and it has predictable effects and also has better bioavailability. And since it has a longer half-life, once daily dose is only required. Thank you.
Thank you, Dr. Blessy. It was concise and brisk presentation. You have done it well. You are a first year student?
Yes, sir.
So you have mentioned about different low molecular weight heparins, enoxaparin, deltaparin. Is there any difference between these agents with regard to the thrombotic, antithrombotic action? Is there any literature showing any difference in action? Because I didn't see any difference. Even though the company people will say that enoxaparin is better or dalteparin is better. Of course, fondaparinux is there. Fondaparinux is a much stronger agent. Okay. Because
for a first year student, definitely she has done a very good presentation.
So, yeah. She has done, it was a good presentation.
Thank you, sir.
Keep it up, keep it up. Very nice.
So all the best for your
Thank you, sir.
coming exams.
Dr. Blessy, can I ask a question?
Thank you, sir.
Dr.
Yes,
Blessy?
Yes, sir. Meenakshi,
can I
Hello,
ask
yes, sir.
anything? How will you reverse
Yes, sir.
fondaparinux? Hello?
Meenakshi, sir, can you repeat the question? It was not audible. It was not clear.
How will you reverse fondaparinux? Audible?
Hello.
You mentioned about the fondaparinux in one slide. It's a long-acting agent. That's the problem with the fondaparinux is it's a strong low molecular weight heparin agent, and it's got a long action, unlike the other agents.
Oh, yes,
Just postgraduate, I am just to sensitize her.
So nowadays we ask surgeons not to use fondaparinux.
That's right, Jayesh. We want to sensitize the postgraduate. There will be exam going. I just
No, she's just joined. She has just joined.
Yeah. She has to read now.
Okay.
Thank you, sir.
So
And
you
Dr.
must have
Ajay,
heard of.
if there is no more questions, we can move on to the next presentation now.
Yeah.
And I think Meenakshi sir want to say that there is no specific agent for agent is available to reverse the fondaparinux. That's all. Thank you, sir.
Thank you, sir.
Dr. Rahul.
Yes, sir. I now call upon Dr. Jinan Abdul Rashid. She is also our first year postgraduate student. She did her graduation, MBBS graduation from Government Medical College, Calicut, Kozhikode. She would be talking upon the equipments, which is microcuff, endotracheal tubes. So I call upon Dr. Jinan to please start a topic. Kindly present a topic, Dr. Jinan.
Am I audible?
Yes, Jinan, you are audible, but you are not. You cannot be seen. Kindly start the video also and share your screen.
Respected teachers and dear friends, a very good evening to one and all. Today I will be discussing on the topic microcuff tubes. Before starting on the topic,
Dr. Jinan, you are not audible.
Jinan, you are not audible.
Traditionally, uncuffed were preferred in children up to 10 years of age. The lack of cuff allows
Dr. Jinan, you are not audible.
in general diameter, and this reduces the resistance and work of breathing. The cuff endotracheal tubes
Hello, Jinan. Jinan, can you hear me? Hello.
I couldn't find her.
Call her over phone and inform her. Her net connectivity is poor. Call her and inform her over phone.
Yes, sir. Yes, sir. I'm doing it.
She is there now. Her connectivity is. Yes, yes. Don't be tensed up. You now it is seen. Carry on.
Dr. Jinan, speak up something. We just want to check your mic volume. We just want to check your mic volume.
Okay, so am I audible? Can I start?
Yes.
You're not audible.
Audible,
Increase the volume.
Increase the volume of your system.
Sir, it is audible only. Jinan, you please speak. You please speak.
Hello, Jinan.
No, not audible.
Am I audible?
Yes.
Yes, yes, yes. Continue, Jinan, continue.
Today I will be discussing on the topic. Today I will be discussing on the topic of microcuff tubes.
Well, her connectivity is
Before
poor.
starting on the topic, I would like to discuss a few words about uncuffed and the
I think Dr. Jinan, you can switch off the video.
Video, yes, yes. She can switch off the video.
That system may have been in low volume. That may be the reason, I think so. Vinil, please see.
Yes, ma'am.
Please ask her to make it as 100%.
Let her
Then
come.
it may be
Back.
easier. You can check the volume of your system so that it will be easier for you to say.
Okay, she's muted now.
Yeah, maybe.
She's muted now. You can unmute and stop the video, and that will be better. I'm trying to stop your video, but now your mic is not detecting. Okay.
Am I audible now?
Yeah, now it's better. You can just stop your video and continue. I think that will be better.
Okay.
Just speak up now.
Okay. Am I audible?
Yeah, better.
Okay.
And speak louder.
Okay. Respected teachers and dear friends, a very good evening to one and all. Today I will be discussing on the topic microcuff tubes. Before starting on the topic proper, I would like to discuss few words about uncuffed and the traditional cuff tubes. Traditionally, uncuffed endotracheal tubes were preferred in children up to 8 to 10 years of age. The lack of cuff allows for a greater internal diameter, and this reduces resistance and work of breathing. Cuffed endotracheal tubes might cause mucosal injury with an increased incidence of subglottic stenosis and post-extubation fluid. This is a comparison between the adult and the pediatric airway. Where we can see the adult airway is more like cylindrical shape and the pediatric airway is funnel shaped. But the newer studies have shown that the pediatric larynx is elliptical with a transverse diameter less than the anteroposterior diameter. The cricoid ring remains functionally the narrowest portion of the airway, and the pediatric airway is more cylindrical like in adults. The problems which arise with the uncuffed endotracheal are the first one is the anatomical variation. This is due to the elliptical shape of the pediatric airway, and the uncuffed endotracheal tube can exert more pressure on the lateral walls of the trachea and larynx. And second problem is the endotracheal tubes with large lead. Here the tidal volume targeted ventilations become inaccurate. And endotracheal tubes, which are too tight, are also another problem. This may lead to airway damage in children. The major problem with the uncuffed tube, that is the endotracheal tube leak. If we minimize this problem, this can allow efficient ventilation, accurate end-tidal gas monitoring, and also reliable respiratory monitoring. And this also reduces the pulmonary aspiration. Like coming on to traditional cuffed endotracheal tubes, the advantages with the traditional and cuffed endotracheal tubes are the adequate sealing of the airway, and this also allows lower fresh gas flows, and this also allows the measurement of the pressure exerted on the tracheal mucosa. The disadvantages of the traditional endotracheal tubes are this can lead to airway injury, and the cuff can be too long and the cuff can be at too high positions. Then there is absent or unreliable depth marks, and there is no reliable size recommendations especially in children. So the topic that is the microcuff endotracheal tube. This is a high volume, low pressure cuff, and it is made up of polyurethane, which is ultra thin of 10 micrometer. There is no Murphy eye in this tube, and the cuff is short and distally placed. And this provides an appropriate intubation depth mark and avoids the formation of longitudinal folds and channels. The puncture strength is almost double, and the burst pressure is more than double when compared with traditional cuffed endotracheal tube. This is the microcuff tube, where we can see there is no Murphy eye, and the cuff is short and it is distally placed where there is an appropriate intubation depth mark. When compared to the other traditional endotracheal tubes, we can see that the microcuff tube have a distally placed cuff, and this reduces the risk of endobronchial intubation. And the sizes of microcuff tubes available are, the smallest size available is 3 mm, which can be used in term babies more than 3 kg of weight. And the largest size available is 10 millimeter. About the insertion of the microcuff endotracheal tube, the correct tube size will be usually smaller than an uncuffed tube. We usually use 0.5 millimeter ID less than the modified Gold's formula. Then it is inserted till the black line at the level of focal cord, and all 4 graded lines are seen above it. And afterwards, we have to inflate the cuff gradually with a 2 ml syringe until no audible leak when ventilated at a peak inspiratory pressure of less than 20 centimeter water. We attach the cuff manometer with a 3-way tap and the 2 ml syringe, and open the tap to the endotracheal tube cuff and measure the pressure. This is the 3-way tap, and this is the manometer connected to the 3-way tap and the 2 ml syringe to monitor the pressures. Ideal pressure for microcuff is 5 to 15 centimeter water. If pressure is more than 20 centimeter water, we have to remove air using a syringe. If a cuff pressure more than 20 centimeter water is needed to ablate the air leak, it may be due to the endotracheal tube and its cuff are too small, or it is too high in the larynx. When monitoring post-insertion, the cuff pressure should be monitored every 6 hours, and pressure should be kept below 15 centimeter water. If leak cannot be abolished by inflation of the cuff to the correct pressures, we have to check the position of the tube. Advantages of the microcuff endotracheal tube: this reduces the endotracheal tube leak, and this causes improved ventilation, and this reduces the chances of re-intubation. Smaller endotracheal tube through the delicate cricoid, and this reduces the ventilator-associated pneumonia, allows lower gas flow rates, and reduces the airway damage. Disadvantages include the price of a microcuff tube is 3 or 4 times higher than a traditional cuff tube, and since there is no mercury endotracheal tube blockage occurs, there is no alternative way of ventilation. Smaller internal diameter increases the resistance, and the inappropriate size causes airway damage. Microcuff tubes have definite advantages over an uncuffed or traditional cuff tubes, but because of the high cost, we reserve it for lung surgeries that demand isolation, postoperative prolonged ventilation where the lungs are bad, pediatric intensive care units, and laparoscopy of full stomach surgeries. Thank you.
Dr. Jinan? Hello?
She should unmute.
Can't hear. Dr. Jinan?
Yes, sir. Am I audible?
Yeah.
Now you are audible.
Dr. Jinan, any disadvantages of microcuff tubes?
Sir? Pardon?
Not audible.
Yeah, actually, it's audible in the YouTube. I can perfectly hear from YouTube.
YouTube, but it's I think something problem with the system.
Yeah.
Okay. Anyway, both Blasi and Dr. Jinan has presented well. Special thanks to Dr. Joy Shankar Jana for the wonderful presentation. I think it was exactly tailored for the postgraduates, especially for the exam going postgraduates. This will be the YouTube and can be a reference for postgraduates to prepare for their final practical exams. It was it will be a good reference for the postgraduates. Special thanks to Dr. Rahul and Dr. Binu Sajid for preparing the postgraduates, and all the best wishes for Dr. Blessy and Dr. Jinan. Thank you. Over to Dr. Binil.
No, I think for wind up the session, we can welcome our president. Madam is there. Madam can wind up. If there is no more questions. Madam, please.
Can't say any questions.
Jinan, is she completed her presentation?
I think so. She hasn't kept the thank you slide. That's all.
And it's well audible in YouTube, madam.
Is it?
What's then the problem in the
last
Some
time
issues from her computer only.
Meenakshi Sundaran sir was asking a question, isn't it? Or to reverse the Ponda paradox?
No, that is just
That is
for
not
the
answered. Okay.
just for the postgraduate. I asked that question.
Madam, sir just wanted to stimulate the postgraduate. That's all.
Yeah,
Yeah.
it is clear. Binil got the point. Binil got the point.
Yes,
I just want to
definitely.
sensitize. See, they should know, even though, see, she's a first year, she has done very well.
Yeah,
This,
definitely. She has
This
presented all the
postgraduate
facts.
is exemplary. This postgraduate is exemplary.